Pause. Okay. Mic is on? Yep. Excellent. Hi, guys. I'm not totally sure if it's because it's Halloween or because of my nerves, but y'all are a kind of scary looking bunch. And I dressed up as a professor today. This is my costume. I'm going to talk to you about CNS infections today. I jokingly called this the presentation where I told you guys the answer is meningitis because that's what everyone tends to think of. But I'm hoping you'll see that it is much more than that. And I'm going to start today with a couple of objectives. I may be the only teacher you have in your entire med school or physical therapy school career to tell you, I kind of hope I don't teach you anything new today. My goal is to synthesize information that you already have from pathology, microbiology, immunology, and a tiny bit of pharmacology. Nothing all that new because I know you guys haven't had pharmacology yet. But I want to synthesize this information to help you understand how infectious organisms gain entry into the central nervous system, recognize the types of pathology they cause once they've gained entry and the common etiological agents for this, and to help you appreciate how this pathophysiology affects the clinical presentation, the diagnosis, and the treatment of these organisms. So I first want to revisit some barriers and portals of entry into the central nervous system. Some of these are going to look familiar from Dr. Harrison's lecture on Wednesday of last week. Organisms can cross the subarachnoid space, going across into the choroid plexus through the blood-cerebrospinal fluid barrier, crossing the blood-brain barrier, also coming through an olfactory portal. Just a couple of ways that infectious organisms can get into the CNS here. And there are 4 different methods that they can go from the rest of your body into the central nervous system. The first and the most common is hematogenous spread. This is a blood-borne spread from a distant focus of infection. So you're talking, these things begin with like a pulmonary infection or endocarditis and travel to the brain. The second is direct inoculation. This may be traumatic, it may be surgical, it may be the result of a congenital CNS malformation, but this is just direct entry from the outside to the inside of the CNS. The next is local extension. I may also call this contiguous spread. And this occurs secondary to an infection that is really close to the central nervous system. So something like sinusitis, otitis, these would spread by local extension. And the final is by the peripheral nervous system. Here we're primarily talking about viruses. And this may sound similar for those of you that are familiar with herpes-type viruses, infecting nerves in the periphery and spreading into the central nervous system. A little bit of an outline of how I'm going to approach the lecture today. Before the break, I'm going to be looking at infections in immune-competent individuals. These are the ones that you will most commonly see in your practices. And I'm going to break this into bacterial infections, including bacterial meningitis and brain abscesses, and viral infections, including viral meningitis, and then focusing on viral encephalitis, on herpes simplex encephalitis. This will take us right up to about 11 o'clock, and then we'll take a break and come back and talk about central nervous system infections in immune-suppressed individuals. We'll finish up viral infections by talking about progressive multifocal leukoencephalopathy, and then we'll discuss fungal infections and protozoal infections with our example organisms here being cryptococcal meningitis and toxoplasmosis caused by Toxoplasma gondii. My goal here is to not give you an in-depth, detail-oriented overview of every single possible infection, but rather to help you see the big picture and the things that you're going to see most often in practice or on step or shelf exams. So there are 4 types of infections that an organism can cause once it gains entry to the central nervous system. The first is meningitis. This is an infection or inflammation in the protective membranes covering the brain and spinal cord. So actually an infection in the meninges. Next are abscesses. And this is an infection leading to an accumulation of pus and inflammatory material with offending microorganisms anywhere in the CNS. We're going to focus on brain abscesses, but these can also occur elsewhere in the central nervous system. Next, we'll talk about encephalitis, and these are an infection or inflammation of the brain itself, so actually of the brain parenchyma. And the last type of infection that we're not really going to focus on today is myelitis, and this is an infection or inflammation in the white or gray matter of the spinal cord. Most CNS infections have a very common presentation, and you're all probably very familiar with this. So a patient comes in, headache, stiff neck, tired, fever. What are we going to do with this patient to know how do we proceed? Because you might have already identified this patient has a central nervous system infection, but is it meningitis? Is it going to be an abscess? Is this neurosurgical? Is this something that I need pharmacotherapies for? Some of these infections proceed from asymptomatic to emergency department presentation to death really fast. And I mean from asymptomatic to emergency department within hours, another couple of hours until that patient is dead. So this is a case where we might want to shoot first, ask questions later. So here we're going to treat first and diagnose later. So our patient comes in, we check, they have stiff neck, headache, fever, they maybe have an altered mental status, and it's entirely possible because these infections cause increased cranial pressure, and there's only so much room in the head, as Dr. Harrison talked about on Wednesday, that these could lead to a herniation if you went ahead and immediately did a lumbar puncture. So our first course of action is going to be obtain blood cultures to help us identify organisms later, maybe proceed on with neuroimaging and lumbar puncture, but then to go ahead and start empiric therapy, just in case this is one of those patients where if you don't start empiric therapy within 30 minutes, that patient has a really poor prognosis. This should look very familiar. Dr. Harrison showed you this slide on Wednesday. And this is, why do we take the blood samples as our first thing? So arterial blood feeds across the blood-brain barrier, joins up with a little bit of cross-communication of things such as glucose with the cerebrospinal fluid across the blood-cerebrospinal fluid barrier. And the cerebrospinal fluid then has interchange with the brain across the ependymal barrier. And this lets us know what is happening in the brain. Are there white blood cells? Is there high glucose, low glucose? Lots of proteins. These CSF chemistry details that Dr. Harrison introduced on Wednesday. The cerebrospinal fluid then makes its way through the ventricles and into the venous blood for disposal, venous blood and lymphatic tissue here. And so any organism that has been in the brain likely gets disposed of in the venous blood, and we can use this to determine cultures, antibodies, etc., what could be affecting the brain. So let's get right into bacterial meningitis, right? Inflammation of the meninges. All forms of meningitis may be classified as acute, subacute, chronic, and the onset of symptoms is going to help tell you something about the etiology. Acute meningitis happens within hours. This is almost always bacterial. Subacute meningitis, so talking about maybe 18 to 24 hours, a couple of days, this is almost always viral. And then chronic meningitis, beginning about 4 days and continuing upwards to 3 or 4 weeks from onset of symptoms to emergency department presentation. This can be viral, but it is almost always fungal. And chronic meningitis is not something you're commonly going to see in an immune competent patient. So we'll be talking about it when we discuss immune suppressed infections later So knowing something about the pathophysiology of bacterial meningitis can help you to understand why do we see the symptoms we see, why do we have the CSF findings that we do, and why do we treat the way that we do. I'm going to spend quite a bit of time on this slide because I want you to understand this and be able to think through this to help you remember what are the CSF findings in bacterial meningitis. What are the symptoms that I expect to see in a patient that has central nervous system infections? And I'm also really afraid I'm going to say this wrong, so I'm going to use my handy-dandy notes. So most of the damage that happens and triggers symptoms in your patients, these are not due to the bacteria. They're due to the immune response to cell wall components that are in the central nervous system when the bacteria lyse. And these cell wall components induce leukocyte migration to the CSF. These leukocytes migrate into the subarachnoid space, and so we've already started increasing the volume in that subarachnoid space. This causes an occlusion of cortical blood vessels, damages nerve roots, and impairs central nervous system CSF flow. This can lead to cranial nerve dysfunctions and also hydrocephalus. And this increased cranial pressure is something Dr. Harrison mentioned on Wednesday as a result of this increase of stuff in the head, basically. This initiates an inflammatory cascade and results in the release of cytokines, oxidants, and proteolytic enzymes. And some of these are things that you've heard about before from Dr. Rob, such as TNF-alpha and interleukin-6. Those sound familiar from his neuroimmunology lecture, right? So what do these do? Well, firstly, some of these are proteins. And so they're going to result in an increased amount of protein in the cerebrospinal fluid. Matrix metalloproteinases and nitric oxide are vasodilators, so they're going to cause the blood vessels to dilate. And TNF-alpha and interleukin-6 are your cytokines. So these cytokines, does anyone remember what they do in the nervous system? Increased vascular permeability, and IL-6 also does something else in the hypothalamus. Fever, exactly. Then this vessel permeability and leukocyte adhesion molecules in the endothelium. This results in an influx of white blood cells. So we're going to see an increased white blood cell count in the CSF of these patients. And the damage to the meninges in response to increased ICP. This increases cytotoxic reactive oxygen species formation, which damages both pathogens and nearby cells. So even more inflammation, more stuff filling that space in the head. This results in both the elevated ICP, but also cerebral edema and irritation of the meninges. And this meningeal irritation is what's going to lead to that stiff neck that your patients are going to present with. Invading bacteria and viruses might also have pyrogens, and that's going to work alongside IL-6 to change the hypothalamic thermal set point. So two different things contributing to fever there. So our clinical presentation, basically I'm going to work through that same pathophysiology again and talking about how are your patients going to present. The classic presentation, only about half of your patients are really going to have this, but it's a triad of fever, stiff neck, and altered mental status, shown here with the red boxes. Other things may include cranial nerve palsies due to pressure on certain cranial nerves, fever and chills from the IL-6 and pyrogens, photophobia, vomiting, seizures, papilledema. and then a couple of physically demonstrable symptoms. And these are signs of meningeal irritation based on that increased ICP. And these signs are only seen in about half of the patients that come in with meningitis. Their absence does not rule out meningitis. So the first is nuchal rigidity, and this is just resistance to flexion of the neck because it's so stiff. The other two are Kernig's sign and Brudzinski's sign. Kernig's sign is you bend at the hip and the knee does not straighten because the hamstrings are so tight. Brudzinski's sign is the neck is so stiff that when you bend the neck, the leg comes with it. So our diagnosis here. I've said this a few times, probably means it's important. If an infection proceeds from asymptomatic to emergency department presentation in a couple of hours, it can proceed to death in a couple of hours. So this is a medical emergency. We want to treat this really fast. As a rule, a few doses of antibiotics or even a single injection of antibiotics are not going to significantly alter the CSF findings, including bacterial cultures, but we did take blood samples just in case, right? Blood samples, maybe neuroimaging if we think there could be cause for herniation, then lumbar puncture. The cornerstone of diagnosis of meningitis is examination of the cerebrospinal fluid. So we're going to do a gram stain, see if we can get a positive identification. But a firm diagnosis is neutrophilic increase in white blood cells due to that vascular permeability, elevated protein levels because we have all of these cytokines coming in, and low glucose levels because the inflammation has blocked those active GLUT transporters from being able to bring glucose from the blood into the brain. And I've heard before that the low glucose is actually because bacteria are eating the sugar to grow. It's not true, but if that helps you remember it, go for it. This is just a summary of what these CSF findings are and a chart that you can use to compare. I'll show the same chart later with what the CSF findings are for viral meningitis and fungal meningitis. So we've looked at the CSF, we've obtained blood cultures. If you started with an antibiotic before you were able to get a lumbar puncture, this blood culture is going to be really important because in case that antibiotic had an effect on the CSF, we're going to use this blood culture to do gram stain and bacterial culture. CSF bacterial cultures are capable of yielding the specific bacterial cause about 70% of the time, but this diminishes if you started antibiotics before getting that. And we can use a technique called latex agglutination to look for bacterial antigens even after we've killed the pathogen. One of the important things you're going to listen for in your patient history is how old are they? So the immune status of your patient based on their age. Are they neonates that haven't had time to establish immunity? Are they older people whose immunity is maybe waning? Or are they college kids? This is going to help you have a good idea of what the causative agent is without even running these tests. So things like listeria tend to show up only in patients that are a little, I don't really want to say immune compromised, but not so good with the immunity. Let's go with that. Whereas in most of your patients, you're going to be looking at Streptococcus, Neisseria meningitidis, or meningococcal meningitis, or Haemophilus influenza. And all of these are aerobic. Almost every case of bacterial meningitis you get is going to be aerobic. So how are we going to treat these patients? We have a couple of important considerations. The first is if your drug of choice can cross the blood cerebrospinal fluid barrier or the blood-brain barrier. And this is important because you need to get your antibiotic to the location of the infection in a high enough concentration and for a long enough time to actually have an effect. And some things that are going to have an impact on this are, is your antibiotic lipophilic? How much inflammation do you actually have? Are you maybe blocking some of the transporters for that antibiotic? And if you remember back to last Wednesday when we were talking about active transport across the blood cerebrospinal fluid barrier, some antibiotics are actively pumped out of the CSF. So we don't want to use those. They don't get a high enough concentration for a long enough time. So we're going to treat with a 3rd or 4th generation cephalosporin and vancomycin. If there is reason to suspect that you might have a weird case of meningitis that has an anaerobic etiology, maybe your patient came in with otitis and then meningitis, then we can also add metronidazole, but that's not going to be common. And this is something that is a little bit controversial. And I'm going to tell you one thing, but then on any test that you have from here on out, I want you to answer something else. And this is, should we use dexamethasone as an adjuvant therapy in treating this? Should we treat ceftriaxone, vancomycin, and dexamethasone, or just the antibiotics? In about 25% of patients that survive bacterial meningitis, there are lifelong neurological sequelae as a result of this infection. And so there's this logic of if most of the symptoms and most of the long-term sequelae are coming from the inflammatory host response, well, let's knock down the inflammatory host response and these patients will fare better. But in reality, dexamethasone treatment doesn't reduce mortality. The patients that it does help these long-term sequelae in, they have H-flu meningitis. And H-flu isn't going to be super common in the US because we have a vaccine for it. So you're not going to see that many patients that would actually benefit from this. Dexamethasone also decreases the penetration of ceftriaxone and vancomycin. So you give it with these antibiotics, and then the antibiotics don't work as well. Doesn't seem like a great idea to me, but it's going to be up to you guys in your practice, maybe even patient to patient, if it's worth giving dexamethasone. But on a test, because I don't want you guys to get this answer wrong, okay? I want you to know why it might be a bad idea to give dexamethasone, but this is the answer I want you to give. Yes, this patient might have bacterial meningitis. I know this one. I'm going to treat them with ceftriaxone, vancomycin, and dexamethasone. Okay? Let's move on and talk about abscesses. So an abscess is accumulation of inflammatory material and offending microorganisms anywhere in the CNS. This occurs by usually direct extension or gets spread through hematogenous spread. Talking about patients that have sinusitis, otitis, endocarditis. So these are often either strep or anaerobic infections, okay? Meningitis usually aerobic. Abscesses usually anaerobic. They may also be polymicrobial. And much like bacterial meningitis is an emergency that you need to treat with pharmacotherapies, bacterial abscesses can quickly lead to herniation, and they need neurosurgical treatment very quickly. So only a few bacteria are needed to create an abscess in the brain. In the skin, you might be talking maybe 10 to the 6th organisms before you start getting an abscess. In the brain, it's 10 to the 2. So not many organisms at all. And once bacteria have established, a brain abscess evolves through 4 different stages, and that's going to affect how it looks on neuroimaging, so MRI and CAT scan. you're going to see how these stages progress. The first is an early cerebrata stage. Back to my notes. I don't want to tell you guys wrong. And here we have a perivascular infiltration of inflammatory cells that surround a core of coagulative necrosis because of the bacteria starting to cause necrosis. There's lots of edema here. This isn't going to show up on neuroimaging. It's the first 1 to 3 days of an infection. Days 4 through 9, this is late cerebrata stage, so finishing up the first week. Pus formation leads to an enlargement of that necrotic center, and this becomes surrounded by an infiltrate of macrophages and fibroblasts. These macrophages and fibroblasts start forming a very thin capsule, and this also involves some reticular fibers. Then by about a week and a half, 2 weeks in, we reach the early capsule stage. This is when you're going to start being able to see an abscess by neuroimaging. Here we get a more complete development of the capsule, and this is thicker on the cortical side than on the ventricle side. And this is because there's more blood flow to the cortex, which is bringing more of these inflammatory cells to that side of the capsule. This capsule is ring enhancing on neuroimaging. And then about 2 weeks in, we have the late capsule stage, and by here we have a well-formed necrotic center with a dense collagen capsule and a zone of edema. We also have a marked gliosis, and this is going to cause some focal symptoms in your patients. An untreated abscess can continue to expand until it causes either brain herniation by mass effect. Again, only so much room in this head of yours. Or it can rupture into the ventricle. So clinical presentation here, somewhat nonspecific, and it's mainly due to having a space-occupying lesion in your head. Headache, nausea, vomiting, all of these things coming from increased intracranial pressure. And we know the cause of this, right? But also because of the gliosis that is localized based on where the infection actually began, we're going to have some focal neurosigns. So these signs and symptoms can be influenced by the location of the abscess. If it started as an otitis infection, it's going to go more towards the temporal lobe or more medially towards the cerebellum. Sinusitis tends to cause abscesses in the frontal lobe, so these are going to affect what sort of focal deficits you see. How big the abscess is, what's causing it, the virulence, and is there an underlying condition? This may all affect what sort of symptoms you see. So bacterial abscess, we're going to look at neuroimaging and treatment together. Treatment is a combination of both medical and surgical. We're going to do an aspiration, get rid of some of the pus out of that abscess. But we're also going to treat with empirical antibiotics, 3rd or 4th generation cephalosporins, and because these tend to be anaerobic, again, I've said this a couple of times now, so this might be important, we're going to use metronidazole, right? So meningitis, cephalosporin, vancomycin, and dexamethasone, abscesses, cephalosporin, and metronidazole. Then we're going to use serial imaging to monitor the response and make sure that this abscess is shrinking over time, and make sure we don't need to perform multiple drainages. The mortality is influenced by herniation or rupture, clinical course of the patient, type of abscess, etc. So now I have a couple of questions. We finished the bacterial portion of this show. And I'm going to read through this question with maybe some emphasis on words that you would pay attention to, and talk through, if you need me to, which response is correct and why the others are incorrect. So a 45-year-old man with no chronic medical problems is seen in the emergency department with fever, headache, and decreased level of alertness, right? Fever, headache, altered mental status. That sounds, I guess, like meningitis, or at least a CNS infection, since that's what we're talking about today. His family reports he had some symptoms of malaise and an upper respiratory illness. So you hear upper respiratory illness and you may be thinking, is that going to be an anaerobic infection pointing us towards an abscess? No, upper respiratory illnesses are usually viral. On examination, his temperature is a fever and his pulse is really high. He has resistance to passive motion in the neck, so that sounds like meningitis. He's moving all limbs symmetrically, so that seems like he doesn't have focal neural deficits. And no other focal deficits are apparent. So which empiric antibiotic regimen do you guys want to give? I'm hearing some C's. Vancomycin and metronidazole, are you guys sure? B? Good job, guys. So the tricky one here is C, vancomycin and metronidazole. If you really wanted to hedge your bets that that upper respiratory infection wasn't something a little more involved than what the patient described or the family described, and you wanted to think maybe it involved some sinusitis, then yeah, you could give metronidazole. You're not going to hurt anything with that. But you're always going to give a cephalosporin, okay? So meningitis, ceftriaxone and vancomycin, abscess, ceftriaxone, and metronidazole. Yeah. Mm-hmm. We will actually get to that. So for those in the back, she's wanting to know what to do if it's more subacute viral. And I'm not going to try to guess the time, but in about 4 slides, we'll get to it. So the next question, since I'm trying to give you the trickiest questions I can think of, and this tells you that my questions are not going to be that tricky. A 26-year-old woman presents with likely bacterial meningitis and a history of otitis, but no other medical problems. So now which medicine do you want to add to the antibiotic regimen? All right, I heard a definitive C, and that's right. All right, moving on to viral CNS infections. So this part, we're going to talk about viral meningitis, subacute meningitis, and we're going to talk about viral encephalitis. And then we'll take a break. And finish by talking about progressive multifocal leukoencephalopathy, PML. I can't ever remember the words unless I'm looking at it. So viral meningitis. In uncomplicated viral meningitis, the clinical course is almost always self-limited. Patient comes in, has all of these things that scream central nervous system infection to you, right? Fever, headache, stiff neck. If it's viral, it has started to show up over the past 18 to 24 hours, maybe 48 hours, subacute, and it's self-limited. This patient's going to be fine in almost all cases in about 7 to 10 days. So the causes here, a lot of times viral meningitis gets called aseptic meningitis, and this is because a lot of times we can't figure out what it actually is before the patient's better, and we don't care anyway. But in those that we can identify, 85% of them are enteroviruses. The next biggest group is going to be herpes viruses. And here we're going to be talking mostly about HSV2 as the common offender. And for those of you that don't have this memorized yet, HSV2 is the genital herpes. May also be adenovirus, measles, mumps, but these are less common because, well, measles and mumps are less common. So the pathophysiology here, viral pathogens gain access via two routes: hematogenous, through things like that upper respiratory infection, or neural spread. So pretty much only viruses are going to have neural spread from peripheral nervous system into the central nervous system. We have a lot of host defenses that are pretty good at controlling viral infections. Local and systemic immune responses, barriers, etc., and these prevent the viral inoculum from causing a clinically significant infection. And so excluding neonates who have likely gotten this infection by passage through the birth canal, mortality associated with viral meningitis is less than 1%, right? Patient comes in, I've felt kind of crummy for 24 hours, headache, stiff neck. They're going to be fine in 7 to 10 days. But that 1%, you do need to keep in mind, and these are usually in more complicated courses. So clinical manifestations, the classics, guys. Fever, nuchal rigidity, altered mental status. You've seen all of these. Again, this is 18 to 36 hours subacute. They may also have nonspecific viral prodromes. So these are going to be your patients coming in a little bit of a croupy voice, and not because they've been talking for 40 minutes straight. Maybe a runny nose, just a little bit of shortness of breath, etc. would not be uncommon here. Photophobia, phonophobia, anything that you can think of that having an increased amount of pressure in the head could cause, you might see in these patients. Other signs can help point towards a specific viral etiology. Enteroviruses, these are GI viruses mostly. So you might see gastroenteritis or rash, and that would indicate an enteroviral etiology. Again, pharyngitis might indicate an enteroviral etiology. And if you have patients with skin manifestations, right, they come in, they look like they have chickenpox. This might be varicella zoster, so a herpes cause of meningitis. And our diagnosis is going to include a CT scan to rule out an intracranial hematoma, mass effect, or obstructive hydrocephalus. We definitely don't want to cause herniation by doing our lumbar puncture, but we are going to do a lumbar puncture, analyze the CSF, and we're also going to do PCR testing for the viral DNA. So how does this compare with bacterial meningitis? The CSF picture is different in viral meningitis. So in addition to timing, we're going to look at some differences in CSF. The opening pressure is less because the ICP is less. CSF cell count is usually in the hundreds instead of thousands. And instead of neutrophils, here we're talking about lymphocytes. Some cases of HSV meningitis or less common etiologies might be neutrophilic early in the course, but mostly we're talking lymphocytes. Glucose is usually normal, and protein levels are usually normal or just a tiny bit elevated instead of really elevated, like what we see in bacterial meningitis. And then our PCR assay is usually positive for a viral etiology here. So our treatment here, to answer your question, it's mostly supportive. There's not a whole lot we can do. In fact, about the only one that we really have a treatment for is herpes. So we're going to have our patient rest. We're going to give them stuff to control their fever, any pain they might have. We're going to give them anti-inflammatories because most of their symptoms are coming from inflammation. Our most important decision here is, are we sure it's viral? And is it worth just going ahead and taking the risk of giving them antibiotics in case? Because in a lot of circumstances, Antibiotics are going to do less harm than having the wrong diagnosis. If we think that the cause is actually HSV, we need to make sure that this isn't going to progress to HSV encephalitis or meningoencephalitis, which is infection of both the meninges and brain parenchyma. And so if we think it's HSV, we may go ahead and give acyclovir. So then moving on to viral encephalitis. So encephalitis is infection of the actual tissue of the brain. Yeah. Mm-hmm. You can stop. In most cases, though, the onset of symptoms is going to leave you thinking this is definitely going to be viral. Because your bacterial meningitis patients are going to come in, oh my gracious, this headache started 2 hours ago and now I can't move. Whereas your viral meningitis patients are going to come in, I've just felt puny and it's not getting better. So viral meningitis versus viral encephalitis. With meningitis, mostly aseptic because we can't identify the cause, but we're going to think HSV2 or enteroviruses. With encephalitis, certain viruses prefer the brain tissue, also mostly aseptic. A lot of times we can't find what the etiology is, but we're going to think HSV1 and arboviruses. So tick-borne viruses, things like Eastern equine or West Nile. And here I'm going to focus on herpes simplex encephalitis. So I've just told you arboviruses, unidentified viruses. Why am I focusing on herpes simplex? Well, HSV encephalitis is going to cause 10 to 20% of the encephalitis cases that you see. And this is the one that is most likely to lead to death. It is also the one that we can treat. So kind of along the same lines of if your patient gets better, it doesn't matter so much what the diagnosis is. Here, if we can treat it, it's the one that we really hope that it is. So this is the one that I want you to know about. In children older than 3 months and adults, we're mostly talking HSV1 instead of HSV2. HSV1 is the oral herpes. And about 90% of us are seropositive for this because we all have that auntie at like a Christmas party when we were 4 years old that was like, oh, just give us a little kiss. And she had, you know, the mustache. And we all have that auntie. In neonates, again, because of coming through the birth canal, we're also going to consider HSV2 here. Before the availability of acyclovir as a therapeutic, the mortality rate from HSV encephalitis was 70%. So 2 out of 3 were going to die from this. The pathophysiology here, we're talking direct neural transmission, so peripheral nerves into the central nervous system, with a typical travel through trigeminal or olfactory nerves, and a preference for the temporal lobe. And this is going to cause us to see symptoms that are focal deficits of temporal lobe involvement. Herpes viruses cause a hemorrhagic necrosis, and so this means we may also see some red blood cells in our samples, and is a major cause of inflammatory infiltrates. Our pathology here, it's a necrotizing inflammation with a predilection for the temporal lobe. Clinical manifestations, it's a central nervous system infection. This is going to be either acute or subacute with our triad. Fever, headache, maybe some papilledema, altered mental status, but because of the involvement of the temporal lobe, we're going to also see focal weaknesses, hemiparesis, memory loss, particularly of newly registered items, memory disturbances, visual field loss, and seizures that may have gustatory hallucinations associated with them. No pathognomic clinical findings can reliably distinguish this from other neurological disorders. And so we're going to consider this in any patient that has a progressively deteriorating level of consciousness. So not just coming in with bad symptoms, but progressively declining, particularly with consciousness. Fever, abnormal CSF, and really we're going to rely on these focal neurological abnormalities. The CSF here, a little bit of a pleocytosis. This is going to be a mononuclear pleocytosis. And as a result of that hemorrhagic underlying pathologic process, this is where you're going to maybe see a little bit of an orange tint or red blood cells in your CSF because these red blood cells are being broken apart. Protein levels are mildly elevated. Glucose is normal or mildly decreased. And you may have positive viral cultures, most likely not. These are not very reliable for diagnosis. But we will do a PCR analysis of CSF for detection of DNA. And the gold standard used to be brain biopsies instead of PCR, but now we have this new technology and it's a lot less invasive than trying to get a hunk of brain. So we're going to depend on PCR. And do you guys know why we would use PCR rather than like an IgM serology? I actually don't know if it's faster and cheaper. 90% of us are going to be seropositive for this, but also right now 100% of us don't have encephalitis. So you cannot count on positive serology to indicate what is the infectious organism. By neuroimaging, we're going to see a hyperintensity in the temporal lobe. And our treatment here. Once we have identified it as herpes encephalitis, we're going to treat with acyclovir. Acyclovir inhibits HSV DNA polymerase, not human DNA polymerase. So if we're at all questioning it, go ahead and give it because it's not going to hurt the patient, only the bacteria. So this is recommended as if you see that progressive decline, those temporal focal deficits, go ahead and start treatment. It's not going to hurt to be empiric with this. And treatment of herpes encephalitis with acyclovir has brought the mortality rate from 70% without it down to 30% with it. I know that still sounds really bad, 1 in 3 still dying, but compared to 2 in 3, it's a lot better. And then a couple of questions and we'll take a break. Which of these CSF findings is not consistent with viral meningitis? Exactly. So when we do have pleocytosis in viral meningitis, viral encephalitis, we're going to be talking about lymphocytes. Bacteria is going to be neutrophils. Normal glucose, maybe a little decreased glucose, both of those are totally normal. Same with protein. Normal protein, maybe mildly elevated protein, totally normal. And the red blood cells are actually going to be your biggest indicator that this might be herpes. And so definitely a viral meningitis there. So then, last question and a break. A 32-year-old, otherwise healthy man is brought into the emergency department with headache and confusion. He woke up with a headache that intensified throughout the day, so a progression of this symptom. Later, he developed a 2-minute episode of poor responsiveness with lip smacking and confusion. So some focal neural deficits there. He has a wife who's a very caring wife and got a little concerned about this, said, "Hon, you have got to go to the ER," and called an ambulance. Upon arrival, he has a fever, and his neurologic examinations are notable for paraphasic errors. He can't recall recently registered items. I've worked on this word all weekend, guys. He has superior right homonymous quadrantinopedia, which is just loss of vision in the upper right quadrant. So we have all of these focal deficits, right? And a Rod-Babinski sign. Which of the following diagnostic tests is most likely to confirm the diagnosis that this is definitely a viral CNS infection with herpes? Okay, I've heard C and I've heard D. Thanks, guys. A is the right answer. So we're going to do herpes PCR. The reason viral culture is wrong is because it often doesn't yield anything. Viral cultures are really challenging, even in like a research lab to get to grow up, and those are absolute optimal conditions for collecting and growing, less optimal in a patient. And serology is not going to be right because most of us are going to have positive serology. So let's take about 10 minutes, meet back about 11. Recording here, yes, that would be excellent. Thanks again for the reminder. So some things to clarify from the first hour. Both HSV1 and HSV2 can cause both viral meningitis and viral encephalitis, but almost always HSV2 for meningitis, almost always HSV1 for encephalitis, and pretty much if you know that, I'm going to be happy, okay? You don't have to remember that maybe like 0.5% of viral meningitis is going to be HSV1. It's a tiny amount, okay? And then the other question was on the use of metronidazole with anaerobic infections. If you're using basically anything antibiotic to treat a CNS infection, it's going to be ceftriaxone and something else. So ceftriaxone and metronidazole, or ceftriaxone and vancomycin. Metronidazole, if it's reason to believe it's anaerobic, and this would be more if it's a brain abscess, right? Abscesses are anaerobic because they're kind of covered with pus and blood vessels are to the outside of that, so they're not getting much oxygen. And they're coming from anaerobic infections, such as otitis and sinusitis. Meningitis, almost always aerobic, which is why you're not usually going to use metronidazole there. So let's get right into infections in immunocompromised hosts. And this is going to be a much shorter section of the lecture. I saw a lot of you getting coffee, and I hope that means you're wanting to be really pepped up for the Halloweeny roast, and not that I'm putting you to sleep. So the type of immune defect that your patient has is going to determine their susceptibility. Patients that have neutrophil deficiencies, more likely to have infections with Candida and Aspergillus. Those with T-cell abnormalities are going to be more likely to have JC virus, Nocardia, Cryptococcus, Toxoplasma, and disordered humoral immunity, strep, Neisseria, and Haemophilus. Well, we just said immune-competent patients have these, so what's going to be the difference? Your immune-suppressed patients, they're going to present with more severe symptoms and maybe some more weird symptoms that you don't normally see in an immune-competent patient. We're going to focus on 3 of these for this talk, and all 3 of these are going to occur in patients that have T-cell deficiencies. We're going to look at JC virus, which causes that PML. I can't remember what it stands for. I'm not going to expect you guys to remember what it stands for. Cryptococcus, which is fungal, and Toxoplasma, which is protozoic. All of these infections can happen in patients with HIV, usually when their T-cell counts drop below 200 or so, or in patients with transplants or other causes for immune suppression, such as complications with diabetes. In your transplant patients, how long they have been on immunosuppressive therapies is going to determine how susceptible they are to certain organisms. So we can see here, patients from 1 to 6 months of immunosuppression, they're more prone to get infections with Epstein-Barr or cytomegalovirus. Whereas at less than 1 month or more than 6 months, we might be looking at Mycobacterium. And you really don't have to memorize this chart. Basically, what I want you to get from this is that the type of immune defect is going to determine their susceptibility, okay? So, PML, let's read it. Well, it's right here in front of us, progressive multifocal encephalopathy. Leukoencephalopathy is what the L is for. So PML is caused by reactivation of the JC virus. And the JC virus is ubiquitous. It is everywhere. As many as 90% of us going to have serum antibodies to this virus. So a lot like HSV1, serum positivity, not going to be that useful. It almost occurs exclusively in AIDS patients and is an AIDS-defining illness. And usually, immune system keeps it in check. So really, you've got to have T cells less than about 100 for this to be a problem. It's considered a slow infection. So we've talked about acute, subacute, chronic. This is a slow infection. We're talking months to years from the time of initial infection. Most of us were infected with this as a toddler, to the time that it presents with symptoms, usually in adults with AIDS. In the pre-heart era, this almost always meant death in 4 to 6 months, but now we have heart treatment for patients with AIDS. So initial infection, we just breathe this, eat it, it's everywhere, and our immune system keeps it in check, makes it latent, and usually hangs out latent in the kidneys, may also hang out latent in the spleen, but when immunity drops, when those T cells drop, we get viremia and central nervous system infection. Once in the CNS, JC virus replicates and starts replicating very quickly. And this quick replication leads to mutations, deletions, duplications in its DNA. And these changes are going to result in even more enhanced replication. So this is going to get somewhat out of control pretty quickly. This infection is lytic, with a preference for infecting oligodendrocytes and astrocytes. And as it breaks up these cells, we're going to have focal myelin loss. And so this is going to cause focal neural deficits because of that loss of myelin and inability then to conduct signal. Infected astrocytes take on a bizarre appearance, and that's not me saying, oh, it just looks weird to me. That is the term that you'll see in the literature, is a bizarre astrocyte. By pathology, we're going to see multiple demyelinative lesions and in the white matter of the brain. This patchy demyelinization is the cause for the symptoms again. Can't conduct signal, you start having symptoms. We have weakness, sensory deficits, clumsiness is a big one. Patient comes in, they've been HIV positive, they've not been taking heart, falling all over themselves, covered with bruises, maybe seizures or behavioral changes. An important thing to note here, unlike other demyelinative diseases, in PML, the optic nerves and spinal cord are spared. So if you see blindness in these patients, it's going to be cortical blindness, not optic nerve blindness. And that is bolded, so it's probably a very important thing to know. Late in the course, these abnormalities may lead to that cortical blindness, dementia, and also coma. Definitive diagnosis is a brain biopsy, but we can also do PCR for the JC virus. If you do a brain biopsy, we're going to see reactive gliosis, a triad of bizarre astrocytes, and demyelinization. We can detect JC virus by PCR, but also in situ hybridization in that brain biopsy. And in terms of PCR, about a third of us will actually have positive urine PCRs for this virus. That's how common this is. And looking around, there's maybe 45 people in here, so about 15 we would show up positive if we tested for this today. Brain biopsies are really invasive, right? Don't want to do them if we don't have to. So how else can we diagnose this? We can base it on this typical clinical presentation, radiographic appearance, and detection of the JC virus in the CSF, because usually it's latent in the kidney. So if it's in the CSF, there's a good chance that it's causing problems in the central nervous system. Cell count and chemistry are usually normal with this, so we're not going to be looking at glucose proteins, anything of that sort. By neuroimaging, it's not very obvious that this is definitely PML. Large confluent lesions with indistinct borders. There's no mass effect. It's hypo-intense on a T1 weighted MRI. There's no contrast enhancement. But we do see something lighting up that really shouldn't be. Treatment here, we don't have treatment. Absolutely no proven specific antiviral therapy exists for the JC virus, so what are we going to do? There is a trial drug, mirtazapine, a little bit better 1-year survival in these patients, but really what we want to do is let the immune system take care of this. So we want to restore those T cells back up above 200. We're going to make sure our patient is on heart. And in the rare instances where this is an immunocompromised patient because of transplant chemotherapy, et cetera, we're going to back off whatever is causing their immune suppression. That was quick and easy, right, guys? Ready to move on. So that wraps up all of the viruses that we're talking about today. Now we're going to move on to fungus. And Neurocryptococcus almost always causes meningitis. Okay, repeating that, it almost always causes meningitis. That is to say, it can actually cause encephalitis, but it almost always causes meningitis. The most common opportunistic infection in HIV patients is actually Mycobacterium tuberculosis, but this is the most common fungal pathogen, and mycobacteria is what it sounds like. It's bacterial. So I wanted to focus on a different etiology for our example organism here. Other causes of fungal meningitis are histoplasma, Candida albicans, blastomyces, and these do occur in immune-competent patients, but very rarely. They're not very common in immune-competent patients. Our immune systems are able to handle these pretty well. So Cryptococcus, if you've had this in MedMacro already, I hope your brain lit up with AIDS patients and pigeons. And if not, then when Dr. Krupa teaches this, I want you to think AIDS patients and pigeons. It's a soil fungus that is associated with pigeon and chicken poop. And it enters the body by inhalation. Then once in the lungs, the yeast come into contact with macrophages, and we get an inflammatory response. So in you and I, immune-competent individuals, this is usually asymptomatic because our lungs come into contact with things all the time. But in a person without a good immune response, this infection is allowed to disseminate to other organs depending on just how immune compromised that patient is. The cerebrospinal fluid is a really great place for it to disseminate. It likes it a lot because the CSF doesn't have complement or immunoglobulins or any of these things that keep it in check. In the rare cases where we have hematogenous spread causing encephalitis instead of meningitis, we have this really interesting pathology. So in the basal ganglia, we see opaque, thick, fibrotic cysts. And this gelatinous material gets called a soap bubble cyst, and it's because they're iridescent when you see them, like soap bubbles. The clinical presentation, this is going to be chronic or subacute meningitis, so a couple of days, upwards to a couple of weeks. Chronic meningitis is almost always fungal. With a severe headache, maybe cranial neuropathies from increased ICP, maybe transient visual obstructions from increased ICP, papilledema. Neck stiffness is only seen in about 30% of these patients, so meningeal irritation is a little less. Up to a third of patients will have disseminated illness elsewhere, particularly in the lungs where the primary affection comes from. And when we compare this with our bacterial meningitis, right? So bacterial meningitis was increased protein from all of the inflammatory cytokines, increased white blood cells from the increased vascular permeability, decreased glucose because of the inflammation blocking the GLUT transporters. Here, we're looking at CSF being characterized by lymphocytic pleocytosis. Lymphocytes like viral meningitis, right? Bacterial meningitis is neutrophils. A reduced glucose level, so that's like the bacterial meningitis, and an elevated protein level. So that's like bacterial meningitis. Opening pressure may be a little bit elevated, and the CSF picture for all fungal meningitis is like cryptococcal meningitis. Our diagnosis here, what's going to help differentiate it besides time of onset, is going to be an India ink preparation. So here we're going to take CSF, we're going to smear it on a slide, we're going to stain with India ink, and much like we would gram stain for bacteria, India ink is going to show us cryptococci. And this is because the cryptococci have a capsule surrounding the spherical yeast, and the India ink is not able to penetrate this capsule. So we get this halo effect around the cryptococcus. By imaging, if we have encephalitis involvement rather than just meningitis, those soap bubble cysts are going to show up as hyperintensities on a T2 weighted MRI, but they're not going to have enhancement with gadolinium. And our treatment here is going to depend on the immune status of the host and which autonomic sites are involved. Anatomic sites, sorry guys. Depending on anatomic sites, we may have some supportive therapy, but our actual treatment for Cryptococcus is going to be usually amphotericin B and fluconazole. And this is going to be used for a long time. In an immunocompetent patient, it's going to be amphotericin B and fluconazole for 6 to 12 months, easy. It's a long-term treatment to get rid of this. In an immune-suppressed patient, we're going to want to make sure they're on HAART. We're going to want to get rid of any corticosteroids or chemotherapeutics leading to their immune-suppressed state. And we're going to give them amphotericin B and fluconazole for as long as their T-cell count is less than 350. So this could be a year. It could be the rest of their life that they're on these drugs. And you can also use HAART as a preventative for this. So as long as their T-cell count stays above 200, you're not likely to see this infection. If they're on HAART, T-cell count is going to stay up above 200 for a much longer period than it would otherwise. Additionally, treatment here, because it is such a long course of treatment, you're going to have increased intracranial pressure for a long duration. And this is an important contributor to its mortality and morbidity. So you may actually use an LP as a treatment here to help just keep that ICP in check. Prognosis is pretty good, particularly in immune-competent patients with fungal meningitis. Mortality is seen in about 10% of patients. But it's higher in your HIV patients, as would be expected. And last organism, guys. Last sample organism. This is toxoplasmosis, and I'm pretty sure you guys have seen this in MedMicro already. So you're thinking pregnant women and cats? Yes? Okay. Toxo is a parasitic disease caused by a protozoan called Toxoplasma gondii, and up to 1/3 of the world's population carries this. So again, serology might not be the best thing to use because there's a good chance your patient is going to have positive serology without actually having CNS infection that is linked to that etiology. Toxo has 4 major manifestations, including congenital from pregnant women, ocular, lymphoadenopathic, and severe neurologic or disseminated disease. And it is the leading cause of focal CNS disease in immune-compromised patients, right? So Cryptococcus is leading cause of fungal meningitis, Mycobacterium tuberculosis is leading cause of any opportunistic infection in HIV patients, AIDS patients. Toxo is the leading cause of focal CNS disease. So this is going to be an abscess once it gets into the brain. Also going to depend on T-cell count. Once T-cell count drops below 100, you have a patient very likely to get this, whereas as long as that T-cell count stays high, your patient's not likely to have this. So HAART is another effective prophylactic for this. If you can keep their T-cell count high, they're probably not going to get it. Transmission here, toxo is predominantly acquired by contact with cat feces or undercooked meat, but you may also see it in transplant patients. Okay, so toxocysts have a predilection for nerve tissue and muscle tissues. The heart, particularly, is muscle, and so you might have a transplant patient that contracts this by having latent cysts in a heart that they've received. And then you're giving corticosteroids and stuff to help with immune suppression so that they don't reject their organ. This is able to come out and cause infection. Toxo spreads through the body, but usually our immune response keeps it in check. So it stays in a latent form. In patients with HIV, it is an AIDS-defining illness, and reactivation pretty much only happens if T cells drop below 100. So your pathology here, you have a primary infection. Usually causes no problems, but reactivation with low T cells. It has a propensity for involvement of the basal ganglia, so traveling from the lungs, stomach, etc., through the middle cerebral artery hematogenously up into the basal ganglia. And you'll see a lot of hematogenous CNS infections actually end up with basal ganglia foci because of coming through that mid-cerebral artery. Clinical presentation. It's usually influenza-like, swollen lymph nodes, muscle aches, pains lasting for a month or more. It is a CNS infection, so they're going to have CNS symptoms. Later, these symptoms progress to confusion, drowsiness, focal weaknesses, and disturbances that are indicative of a basal ganglia involvement. And this can progress to coma in days to weeks if it's left untreated. Definitive diagnosis here is going to be based on the neuroimaging. A compatible clinical syndrome, identification of one or more mass lesions in that neuroimaging, and detection of the organism by PCR. Also IgG, but IgG is not going to be great here. On the imaging studies, we're talking about multiple lesions. Hematogenous spread organisms that cause abscesses also tend to cause multiple lesions. They're ring enhancing. And do you guys remember what part of an abscess causes that ring? Starts to be apparent in stage 3, the mid or early capsule formation. And it's going to be in the basal ganglia. And here we can see multiple ring-forming lesions with a predilection for the basal ganglia. Treatment here. Pyrimethamine and sulfadiazine are going to be your primary ones of treatment. And then last question, guys, and we're done, and you can go eat hot dogs. I think this one might actually be the trickiest one of the day. A 55-year-old man undergoes a bone marrow transplant, which makes you start thinking maybe he's immune compromised, or maybe just the fact that this question's in the second part of this lecture makes you think he's immune compromised. Chronic myelogenous leukemia, but he has complications and receives cyclosporin and prednisone to treat graft versus host disease. 6 months after the transplant, he develops progressive rut hemiphoresis and some focal neural deficits. So you ask, where have you been, man? And he says he's recently traveled to Mexico and the Midwest US and been camping, where he got a bunch of mosquito bites. So that might make you start thinking, could this actually be some viral something from an arbovirus? He has 3 cats at home, so now you're thinking, oh, maybe toxo. MRI demonstrates multiple areas of abnormal T2 signal in the white matter. So the white matter involvement says PML. Largest of which is in the left frontal lobe, and there is minimal mass effect and no contrast enhancement. Definitely sounds like PML. And the censure on this is that the CSF analysis was positive for JC virus, so definitely PML. Which feature of his history is the most significant for that? See? All right, excellent, guys. C, graft versus host disease. So this is going to mean that his C cell count's really low. And JC virus is everywhere, so exposure to cats, mosquitoes, and travel are not going to have any bearing on this. Last couple of slides here, I've just made a table with all of the CSF findings in one place, so you can do a comparative memorization, I guess, here. And then movement of CSF through the ventricles in case you need to think about that in terms of the pathophysiology, how communication between the brain and CSF would occur to be able to have our CSF chemistry that we've talked about. I'll post a Word document this afternoon with the answers to these questions and the logic behind the answers. So if you didn't catch those on notes, they'll be there. Again, handouts are posted now. And if you have any questions, my email is actually in the syllabus, so you can direct those to me.